Terry Hill at Rural Health Innovations. Welcome, Terry.
Thank you very much, Cassie. And I'm excited about this afternoon's agenda. We're going to be talking about moving towards healthcare transformation. And I'm going to start it out kind of on behalf of our Center and Rural Health Innovations to talk about kind of what we are seeing in terms of the evolution of the industry into value-based payments, population health, et cetera. And then we're going to have 3 speakers from our networks talk about what is happening in their individual regions as well. And that is going to be kind of an exciting combination of what is happening in various parts of the country. And I'm really looking forward to it. So with that, let's move to the first slide. There you go. So again, one of the things I want to point out here is this is kind of a revived focus areas for our National Rural Health Resource Center. We have a responsibility towards being kind of looking at what's happening nationally on the transition to value and population health. Besides this program, which supports all of the rural health networks, we also do work on the ground, working with quite a number of rural hospitals and clinics kind of on site. We oversee the Technical Assistance and Services Center, which basically is the Medicare Flex programs for each of the states, et cetera. And you can see we have a pretty diverse portfolio of responsibilities and expertise as well. So today we're going to be looking at that first bullet, transition to value and population health. The existing system, I mean, the bottom line here is that our American health care system is at the point of almost bankrupting this country, particularly if it's to continue as it has been. In essence, we have far and away the highest costs in the world. The last time I checked on the World Health Organizations, I think they're ranked as 37th in terms of quality. An extremely high chronic illness rate, and up until recently, with the expansion of the Medicaid program and the Affordable Care Act, we had 50 million people who did not have health insurance. Now, this is where we're moving. You've heard this before. And really, it is going to define the value of our future healthcare system. We're moving to better healthcare, better quality, smarter spending, read less waste, and just basically costs that are reasonable and are appropriate, and finally, healthier people. We're going to do something about the chronic illness epidemic, and I'm firmly convinced we're on our way, and I'm also firmly convinced that rural healthcare providers and rural communities are going to play a really vital role. Now, the evidence, I think, is really pretty clear, but this one is really pretty apparent in that regard. If you look at this slide, you see that the federal government, this is one of the Department of Health and Human Services' own slide, predicts that by 2018, 2 years out, over 50% of the payments will be in the alternative payment models, read accountable care organizations, et cetera, that a full 90% are going to be value-based, and there's a very tiny piece that will not be based on value or on population health, and the intention is to almost take everything and move it into this stream. The progression to date has been probably even more rapid than we anticipated, and what I can tell you is that the rural providers moving into value-based models. The speed at which they're doing it is even faster lately than it has been in rural, in urban areas rather. This is another slide that really talks about where the industry is going and how fast. The accountable care organizations, which I'm going to talk about in a few minutes, are a major part of that, which goes across the top. There are pioneer ACOs. Most of them have been urban-based. There are new models. There's next generation ACOs, et cetera. Bottom line is, as of January 1st, there were 41 accountable care organizations that were launched in rural America. Partly that was due to the fact that there were forgivable loans made available to the AIM program. But as you can see, besides accountable care organizations, we're talking about bundled payments. For example, there's a major new initiative that is going to give a comprehensive amount of money for any type of joint surgery. We also can see that the joint replacement in particular has to be looked at, and then oncology care as well. Advanced primary care, which really starts talking about the medical homes and other models as well. So for those of you that may not be familiar with this concept, a lot of people in healthcare are starting to understand it and starting to basically plan for it. But in essence, it's really pretty simple, that it's a mechanism to actually place the responsibility for the comprehensive care of a group of individuals, not necessarily patients. In accountable care organizations' case, it's Medicare recipients. You have at least 5,000 of these Medicare recipients, and the responsibility for the cost and the quality basically fall on these accountable care organizations, largely made up of hospitals and clinics. That's the primary group as such. Now, let me get back here. What we know is that the outcomes, if we are responsible as providers for the outcomes, look at this slide. I find this really very compelling. Basically, according to most research organizations and authoritative organizations, only about 20, when you take the genetics out of it, only about 20% of health outcomes will be attributable to clinical care. That means the rural hospitals and clinics and our ACOs are going to have responsibility for outcomes, but they're not going to have anywhere close to even the majority of influence about those outcomes. Even larger determinants here include health behaviors, what are people actually doing, social and economic factors, which speaks to the need to deal with poverty and other socioeconomic factors, and kind of the physical environment as well are certainly going to be very influential. And we made this slide especially for this session. That means, I mean, almost by definition from the accountable care organizations, last count 700 or 800 of them nationally, and a growing number in rural, we're going to have to work together here. It's going to be churches. We have some networks that are focused primarily here on churches. It's going to be long-term care, home care, et cetera. It's going to be about housing. It's going to require partnerships with public health service providers, government, businesses, schools, mental health, and emergency services as well. It's all going to have to work together. Now, what does that look like? It looks like a network, and that's a fundamental thing that I can say. What we see is accountable care organizations growing. We have quite a number within our own group of development networks. There are one of them whom we're going to hear about today, which is in Texas. We also have one of our development projects that are overseeing two accountable care organizations out of Colorado and Washington, et cetera. So we're moving in this direction, and fundamentally at the base, we believe are networks. And networks are going to make these payment models work. They're going to create infrastructure. They build trust and collaboration. Think about these partnerships. We get a group of hospitals and clinics. They're going to have to work together because they're not individually, they're not large enough to bring the needed number of covered lives to the table. And the networks provide this base of support for them. It provides a means for sharing and analyzing information. It creates collective volume, and it creates economies of scale as well. So it's a point we wanted to get across right from the very beginning here. We need networks, and our networks become kind of the laboratories for rural value-based innovation. And ultimately, and this is our bridge to value and population health, we're heading towards a health system that links healthcare with community stakeholders, create a network of organizations working together to improve the population health of American citizens. So with that, we're going to hear from our panel of speakers. Our first network is basically the North Coast Quality Improvement Network, and we have Tim Ryan and Tricia Cook here to talk about what they're doing and the type of innovation that we're seeing in Northern California. So I will turn it over to Tim and Tricia.
Hit star 2 to unmute your line.
Thank you, Terry. We appreciate the opportunity to share. My name is Tim Ryan. I'm the Executive Director of the North Coast Clinics Network, which is a consortium of community health centers serving the rural residents in our community. A little organizational history for us is started originally back in 1992. We had a lunchtime group of clinic directors and administrators, which began holding regular informal meetings to share information and concerns regarding the potential implementation of managed care in the hopes of structuring some sort of effective strategy and response to the health industry. So the health centers that make up our network, we are an HCCN, or a health center controlled network, and we evolved from that group of administrators and leaders. And today we encompass a large portion of the northwest corner of Northern California, the counties of Humboldt, Del Norte, and Trinity. Back in 1995, we were incorporated as a 501c3, and the North Coast Clinic member health centers collectively strive to improve access to high-quality care, medical, mental health, and dental care as well, regardless of the ability to pay. We exist here at the network to assist our members in these efforts to meet the needs of the community and the needs of the clinics themselves through information sharing, community education, some shared administrative activities, as well as direct service projects. We continue to be recognized as a convener, facilitator, and thought leader across the region for the rural community health centers in Northern California. And the network also successfully implements effective programs, advances innovative solutions, and leads local initiatives to improve the health system and the rural populations we serve. The vision here at the network is our rural residents on the North Coast will lead healthier lives as a result of collaborative partnerships with health and wellness providers and through education and access to family-centered integrated health systems. So just a little bit more about us. As I mentioned, we're in the northwest chunk of California. We border the Pacific Ocean and the state of Oregon. We're located approximately 200 miles north of San Francisco, extending through the Oregon border. And our region, if you were to flatten it, serves is roughly the size of Connecticut, however, with only 5% of the population numbers. Communities are small and isolated, sometimes mountainous, others are coastal. We have a mixture of federally designated rural and frontier areas, and our largest city, Eureka, has a population of about 36,000 individuals. Like most of you, between poverty, healthcare provider shortages, high rates of multiple chronic diseases, residents face even more barriers to care, which intensifies the need for providers to be systemic, and hence the network comes in. We tend to rank, unfortunately, 43rd, 44th, and 54th out of the 57 counties in California in the overall health ranking, so underlying some troubles with our population as well. The network membership is made up of 3 federally qualified health center corporations with 15 locations. Those permanent locations, additionally 6 satellite locations, and then we have 2 affiliate members with a local Planned Parenthood as well as our public health department. In 2015, we saw 1 in 3 individuals, which was roughly 60,000 patients and over 250,000 encounters. So I'll hand it over to my colleague, Tricia Cook, Project Director here at the North Coast Clinic Network, to talk a little bit about our HRSA Network Development Grant.
Next slide, please. So our Rural Health Network Development Program's overall goal, as you can see here, is to improve population health by implementing promising practices and evidence-based approaches to address health disparities in our communities through the use of technology and collaboration. And we kind of moved in this direction out of a growing need within our members for support and education on data analytics and quality improvement as the healthcare system was moving from volume to value, and numerous programs were available to incentivize health centers in this shift, such as meaningful use and patient-centered medical home recognition. It became especially needed as our health centers had a recent shift into a Medicaid managed care health plan where they were having a per patient per month payment model and also the opportunity for quality incentive program dollars. Some of our main chromatic areas. First, we wanted to effectively integrate a population health data analytics tool called PopIQ into our consortium across the region. 2, we wanted to appropriately train network and clinic staff on the model of improvement by providing technical assistance to clinic staff on evidence-based strategies to improve population health through the use of data and also patient engagement. 3, we wanted to create a culture of continuous quality improvement through the collection, aggregation, and analysis of clinical and operational performance measures, basically moving us in a direction to being able to make data-driven decisions. The measures for our project include A1Cs above 9, childhood immunizations, well child visits for children aged 3 to 6, childhood BMI with nutrition and physical activity counseling, cervical cancer screening, colorectal cancer screening, and then we had both operational and financial measure, third next available, and looking at payer mix and federal poverty level of our patient population. And then last 2 were to foster peer network and expertise exchange through our numerous peer networks, one of which being quality improvement and via a regional collaborative. And then to, of course, kind of explore in evaluation and sustainability activities in order to ensure that we would be able to continue to provide these activities and programs for our health centers beyond the time of this grant. Next slide. So this kind of encompasses the 3 main areas of our program. And in the first year of our grant, the 2 big endeavors that we undertook were to create an assessment to see where our health centers were currently at as far as QI and data analytics capacity, and then to do initial mapping and data validation of the PopIQ tool. This tool having done the data mapping and data validation, has been invaluable to our health centers so that they can trend data over time. They can compare themselves to other health centers in the region, and they can also develop individual reports using a variety of filters such as gender, age, and financial class. So as we started, we administered a QI assessment to both health center staff and also executive staff. And this assessment measured kind of the perception of the culture of QI within the health center, the makeup of care teams, the team dynamics, team skill sets, and kind of the likelihood of the care team tasks occurring on a regular basis, such as chart scrubbing and huddles. So once we got this assessment back, we collected and aggregated and analyzed it, and basically the top priorities that came out were the development and enhancement of care teams, the integration of huddles and chart scrubbing, basic trainings for QI and data analytics, and one that we weren't expecting was communication and team building across the organization. So upon finishing that, we also did a literature review and search for best practices about the configuration of QI departments with a growing need to run rosters of patients and manage data. We wanted to see what was out there and what folks were doing. And so over this time, these first 2 years, we've really grown the QI departments and helped with that process within our health centers. They have added population health managers, a lot of times who are former medical assistants within the health centers who's kind of moved out of that role to kind of focus mainly on data cleanup and patient outreach. And then one of the last elements of culture change that's been really transforming is incorporating patients into the work. So our health centers have created patient advisory boards. So these patient advisors do clinic walkthroughs, they make recommendations for improvements in the health center, they review patient education materials, as well as sit on some of the already formed QI teams and give input there. So in the training and education, you can see this is laying the framework to build that infrastructure. So we have the ABCs of QI, which is a basic QI training. Treating patients with care is a communication training to build team and bring empathy back into our conversations. Trauma-informed care, of course. How do we work with patients, especially in our area? We have a high instance of patients coming to us with previous trauma. Motivational interviewing, so that patient engagement piece. And then the Staying Healthy classes in our Pathways to Health are both programs, the first dealing with helping kids and families maintain BMI and healthy eating and active living. And our Pathways to Health is a self-management class for patients to help them deal with chronic conditions. And then lastly, we have acted as improvement advisors. We worked with our clinics on such projects as a Well Child project, where we help them develop workflows. And as a result of this, they have increased the percentage of Well Child visits that they're able to deliver. In the first year, it was 10%, and I think now we've improved almost 20%, 25%. And then lastly, we provide our health centers with quarterly dashboards, which we review with them. They're posted for all staff to see. They've prompted healthy competition. One of our clinics for Colorectal Cancer Awareness Month had a competition to see which care team could give out the most fit tests, and the winner received a Starbucks coffee card. So we've really been successful in integrating QI into everyday work as well as at the base of the organization. And then lastly, we're focused on social determinants of health, and so we've worked with our health centers to put community gardens in, connect patients to vouchers for the farmers market, create walking paths, so really getting at that kind of upstream intervention as well. Next slide, please. And then as far as moving towards this value-based population health, we have the Keeping It Rural Collaborative, which came together out of a need to elevate the rural voice on a state and federal level and to support Northern California health centers in their efforts to achieve the triple aim. The collaborative saw the best way to do this was by supporting peer network and expertise sharing through data analytics and data-driven decision-making and through partnership building and collaboration. So we have 13 health center controlled networks that have 17 FQHCs with 46 sites. It's a huge spread, that's pretty much Northern California, 13 counties covering a 40,000 square mile landscape. So with our peer networks, currently we have 5, so CEOs, COs, CFOs, QI, outreach, and enrollment. And really this is an opportunity for folks to come together and share best practices and questions and kind of move through all this evolving healthcare landscape. And then in the realm of data analytics, we've really focused on trying to create data transparency across all of these consortia, and we've done various projects where we've taken the HRSA UDS and aggregated it by size of clinics, so small, medium, and large clinics, to see as a region how are we performing and what kind of education or interventions can we make collectively. We've created data sets to kind of tell the story behind the data. What are the clinics doing and what are the challenges that they face? We're looking at alternative access and payer mixes as well as social determinants of health data. And then lastly, with our partnership building and collaboration, we've had some really innovative projects, one of which is a health awareness and prevention calendar, where each month we focus on a different measure, whether it's cervical cancer screening, colorectal cancer, and collectively we do PSAs, education, patient education, and we've worked very closely with our Department of Human and Health Services, our IPA, the food bank, local family resource centers, as well as very closely with our Medicaid managed care plan. Specifically with our Medicaid managed care plan, we've been invited to the table at this point and to strategize about how we're going to approach QI and innovation in the North State, which has been huge. And then lastly, we have the Regional Associations of California. These are 14 healthcare networks, and they've come together multiple times a year to look at statewide strategies around policy and advocacy as well as programs. And one example of a recent activity is we conducted a statewide workforce needs survey to get a snapshot of where shortages are and new positions that are evolving due to this movement in the healthcare industry.
All right, I'll wrap up quickly for the last slide for the lessons learned. So as you can see, some of the lessons learned is, back to Terry's point, a network does serve a role as a convener and a facilitator. The ability to work with external stakeholders as well as internally with our member health centers to create buy-in. One of the things we also learned is the diversity of skills and locations in our rural areas aren't always consistent. So we've got outlying frontier areas where it may be one provider isolated by themselves to really try and build the infrastructure. The other piece is the competing demands for data. Everybody seems to want data all the time and to be able to manipulate it, whether it's locally, the managed care plan, the health information exchange is always coming. So externally, you've got changing definitions and requirements for meaningful use in UDS, as well as internally, what are the population health needs that our communities are asking for. The last one is really looking at healthcare access and QI capacity. Since there's limited access in our rural areas, how do we make QI a focused area, and how do you focus on it when you can't meet the current needs walking through your door? Back to Tricia's point, we do have some extensive networks for sharing best practices locally with community organizations, regionally with the QI and several of the groups Tricia had mentioned previously, and then again at the statewide level, all coming together as health center controlled networks to address statewide systemic issues. And Terry, I'll go ahead and send it back to you in the studio, knowing we're out of time, but look forward to some questions later. So thank you for the opportunity.
Thank you. Really great. You guys are doing terrific work, and it's you know, as we know, eventually we're all going to have to work together as provider types as well. But the infrastructure that you're building, I really like the emphasis on patients too. That's really outstanding. Our next speaker is Tara Dilley, who's with the Texas Rural Accountable Care Organization, and she's going to talk about innovative ways of achieving the triple aim. So Tara, I'm going to turn it over to you.
Hi, thank you, Terry. As Terry mentioned, my name is Tara Dilley. I am the Executive Director for Southeast Texas Health System, but I'm the Program Coordinator for the Texas Rural Accountable Care Organization, or TRACO, as we refer to it. A little background on our parent network is Southeast Texas Health System. We also refer to it as SES. We were established in 1994, and we are independently owned by 9 independent facility members, and they make up a combination of critical access hospitals, rural PPS, community health centers, FQHCs, RHCs, and independent physician clinics. If you look at the state of Texas, geographically, we are located along the Texas Gulf Coast. Our farthest member is not far from Corpus in a town called Victoria, and if you move up the coast towards Louisiana, our farthest member over to the east would be Anahuac. And so the mission of SETH is to integrate healthcare locally and regionally for purposes of responding to the growth of managed care in a way that preserves local control and maintains the independence of a member institution. And SETH came about because, everything was moving to the managed care world. And, when you start looking at small facilities, critical access hospitals, rural hospitals, we didn't have the patient volume. And if it was just one facility trying to talk to Blue Cross Blue Shield or, Aetna, any of those big guns, you didn't have the patient volume, so it's not like they could really take you seriously. So SETH was grown from the idea of if we come together as a collaborative, we bring together more patient lives, multiple sites, and so this has given us the ability to be able to negotiate contracts, for better reimbursement, and we've also had a lot of luck in the contract language. And but aside from that, one thing that SETH prides itself on is, when we do receive any type of HRSA grant funding or any other type of funding, our network is not run dependent on any type of grant. Our members pay to play. So if there's anything in particular that they're interested in participating in with whatever that project focus is, they don't get it for free, because we found throughout the years that, when you get it for free, a lot of times you don't have the ownership. So, when our members are paying for something, they're more inclined to, to have ownership of that particular project. And so the sustainability of our network, we've been very fortunate, through multiple product and service lines that we have, which, we have an IPA, which is a SETH physician organization. We have a preferred provider network. It's called CRIS, which many of our commercial and self-funded members use for their health plans. The large portion of it is our managed care contracting service. We utilized a small healthcare QI grant to establish our accredited outpatient diabetes self-management training program. And we also connect our providers with, we just partnered with Greater Houston Health Connect so that they have access to connecting to an HIE, since the majority of our members refer into the Houston area. As stated, we've been very fortunate through the years to have received grants for outreach, small healthcare QI, and 2 network development grants with 2 different projects. This particular project, PRACO, was formed in response to the changing landscape of healthcare. And, basically, the rural providers are being faced with the challenge to transform their delivery system from cost-based and fee-for-service or, pay-for-volume to care management and population health, which is pay-for-value. And so navigating through the ACO requirements from a rural perspective is the intent of our grant. We are in year 2 of our grant. We started in January 1st of 2015. As Terry had mentioned earlier, it takes 5,000 lives to even become an ACO, and collaboration and working with partners, and even partners that you've never worked with before, may be required if you want to go into the ACO world, and that was the situation that we were in. In 2015, we actually had 8 members, 6 of which resided in the state of Texas, and 2 were outliers. One of our members then was a health system in Missouri Delta, and another one was a large physician group in Tahoe, Truckee. And, initially when we ran the preliminary numbers to be an ACO, it goes off attribution. And, Medicare uses their fancy formula, and they come back and they give you the number of lives that they're going to attribute to you. And if you're not going to hit the 5,000, then your ACO is not going to happen. So our preliminary numbers came back and said that we were not going to hit the 5,000, even with the 6 Texas sites initially. And so Missouri was hanging out there by themselves with about 2,500 attributed lives, and I think around 1,500 or 2,000 is what Coffee Truckee had. And so it just made sense at the time, and to just come together. So I think an ACO of that type of design alone shows that that's collaboration at its best. And because within an ACO, you are relying on your partners. You're in this together. You may do your best at facility A to move that needle and lower costs, but if facility D isn't doing their part, it's going to negatively have an effect on the entire ACO. So, but moving into 2016, due to some AIM funding that CMS offered, California went into their own ACO, and Missouri Delta dropped out of Texas. So the Texas ACO now only has the 6 Texas sites. And they are a combination of critical access hospitals, rural PPS, community health centers, FQHCs, RHCs, and independent clinics. And as Terry mentioned also, about working with your community partners, one of our members that's in SES and the ACO doesn't own any clinics. And he's probably about the only community within all the ACOs that has that type of relationship, that he was able to convince the importance of an ACO to 5 independently owned clinics in his community, and they all joined last year. So, how are we addressing healthcare transformation? We feel that, we do have 1 year underneath us. Last year was a huge learning curve for everybody. ACO was a term most people, even within our network, they were hearing it, but it wasn't, the whole process of an ACO wasn't something that they were discussing at every single board meeting. So in our particular communities, I'm going to give you a community, snapshot of how our ACO is working. And what's working in one, although a few things behind the scenes may be different, the actual structure itself is in place at each one of our 6 facilities. So in addressing the healthcare transformation from the ACO standpoint, we have strong, respected leadership within each community. And the majority, the leader on all of this is the CEO or CFO, depending on the member we're talking about, has the relationship with those clinic practices, with those providers, with outlying, home health, hospice, you name it. And so we feel that, if your community is going to be making the shift and the change to be an ACO, you have to have strong and respected leadership in order to get this project moving and to keep it going. Each one of our communities employs an RN care coordinator. And what the RN care coordinator does is, the priority is to cross-reference the internal data that CMS provides us to identify the top 10 to 15% of high-cost utilizers attributed at each site to their own internal data. The attribution list actually changes quarterly, so it's not like they can look at it January 1 and say, okay, here are our top, 40 people we have to go after. It's every quarter that list is changing. And, that care coordinator is really the nucleus of an ACO. Yes, you have your CEO and you have project managers and everything, but if you want a program to really take off, you've got to have an effective care coordinator in place. The care coordinator has to be able to engage providers to address the patients that they've identified, and then, be able to confidently meet with these patients and create individualized care plans. And engaging providers and practice managers, that was something that was a little difficult in year 1, but I have to say, since we've been able to see how well some of the care coordination has gone for some of these patients, for some, even those physicians that were resistant against the whole ACO and care coordinator piece have become so engaged in the program, referring to the care coordinator. Utilizing CMS data, Part A, B, and D, and quality scores to identify high-cost providers and facilities. a unique aspect of going into an ACO, which, it's not your managed care Medicare plan patients. It's fee-for-service Medicare patients. The advantage is as soon as you become an ACO and you get your attributed list, you get the current claims data and 3 years prior. And being able to utilize this data, it's so incredibly powerful. When I say, to identify high-cost providers and facilities, the data warehouse that we use, we have the capability of going into a Part A claim and, pulling like a snapshot of a community. And, a lot of times you think that you're the sole provider within your community, that you have the majority of the patient care. And it's a real eye-opener when you actually have the claims data, because you are capable of looking at all the claims. You're looking at the whole patient, whole picture of the patient by getting all of the claims data. And, we have found across the board with our 6 Texas hospitals that they have 25 to 40% of the Part A claims. So they are not providing the multitude of care along the lines of a Part A claim. If you look at Part B, the data gets so finite that you are able to look at who was the doctor, what was the procedure, even with medications on Part D, who's the doctor who wrote the script, who's the pharmacist who filled it. These are the dates that the pharmacy, filled this script. And, one particular ACO was able to utilize just the Part D claims data to be able to identify a patient who was receiving an annual shot that cost $20,000, and there was another medication as effective as the $20,000 one that would require a monthly shot for $100. So I mean, just one patient, one medication. Look at this. Look at the savings they had on that one patient. So that's the importance of using this CMS data, to move the local area, to move that needle. Shifting how providers work together. This has been interesting because, we really push the annual wellness visit with quality scores and everything. And some, providers get very territorial over who their patients are. And, some workflows within clinics have had to change and adapt to make up for the needs of, these attributed patients to make sure that we're getting them in for, annual wellness visits or meeting quality measures, or getting the quality measures reported before it's time to, record them at the beginning of the year. And so, they've had to really shift how, their mindset and how they work, whether it's, working through the care coordinator, the quality metrics and reporting, engaging other people within the facility to help with that, and then shared patient care. Who are they sending out to? Are they duplicating tests? Why are they duplicating tests? So that's a lot of how our ACO is looking at when we're looking at healthcare transformation. We're hitting a lot of these bullets. In preparing our members, for success within the ACO, I can't reiterate it enough, the importance for each one of our sites to utilize their Medicare claims data. It is the whole picture of health for a patient. And at the same time, it's going to help them identify their community partners. Because, think of a patient, when you're looking at the whole patient care, it's not just their they stayed in the hospital, they went to the clinic, they get their drugs. Were they in a skilled nursing facility? Did they receive hospice care? Are they receiving home health care? And where are these costs that are associated with all these other pieces that this patient, that are involved in the picture of health for this patient? And that's why, utilizing that Medicare claims data and acting upon it is probably one of our biggest pushes right now. Then, engaging care coordinators with providers. Again, looking at that caseload, making the priority the top 10 to 15% of the high-cost utilizers, because that top 10 to 15%, those patients comprise the majority of your Medicare spending. So even if you can have just a marginal effect on your patient, on your caseload for those patients, you're going to save money. And and all our ACO is an MSSP, a Medicare Shared Savings Program. So if the ACO as a whole can save money, Medicare gets 50% of it, and our ACO gets 50% of it. And then on top of that, they have to meet certain quality measures which can determine what their actual savings is. So we're all working towards the same goal. And like I said earlier, the care coordinators have to continually cross-reference internal patient data to the CMS attributed patient data, because it does change quarterly. And because some of our communities, butt up to other communities, there is the chance that a particular patient could fall off of, facility A's attribution list and be picked up by facility B, because the bulk of their patient care actually fell within another provider at another facility. So it's an ebb and flow type thing, and then of course patients die, and then you start seeing people who just turned 65, and so you're getting newer people on your list. It's constantly changing. And also preparing for our members for success is utilizing existing and new reimbursement codes, and this has kind of been a little bit of a sticky subject for us on year one, because chronic care management, or CCM, is available to be billed, but FQHCs and RHCs were not able to do that last year. They can do it this year, but there are 17 steps required in order to bill for CCM, and even some of our facilities don't meet that billing requirement. And primarily it's because whatever EMR provider they have, they've basically been told that they're not going to support that or be a certified EMR, and that's one of the requirements to bill for CCM. Transitional care management, this has been a very popular service that all of our providers have offered. Transitional care management, if you're not familiar with it, is a 30-day type program, and day one starts the day the patient's discharged. And this has been a game changer for many of our facilities, in that you have 30 days to show this patient and to gain their trust of what the care coordination program is all about. And if they're a high-cost utilizer, they're a little bit doubtful of what are you going to do for me, since TCM is only for 30 days, you have that 30 days to gain their trust. And we've seen a large shift in caseloads of patients coming out of TCM and being referred directly into CCM. The trust is there with that care coordinator, and we've seen success in keeping them out of the emergency room, making sure they make their clinic appointments, etc. And a new one this year is called advanced care planning, advanced directives, those types of things. And if it's performed within an annual wellness visit, you cannot bill for it. But if it's performed outside of an annual wellness visit, you can bill for it. So this is a new service. So a big thing about ensuring their success is, making sure they're billing for everything that they need to be billing for. Increasing annual wellness visits. There's 17 measures that a clinic reports on for an annual wellness visit, and for quality measures, and 11 of those quality measures are captured during the annual wellness visit. And so, this alone helps you in the fact that if you can, now that RHCs can, itemizing your billing, once it hits Medicare and the claims data comes into our data warehouse, we're going to have the information and the data there supporting that quality measures were met, so that while we work on facilities getting their flat files, or basically the clinic information, into the data warehouse, the claims data will show the quality measure was met, and the flat file information coming in is going to be the supporting documentation for the quality measures. Lessons learned, and the main one for us is established peer communities. That's been a big success for STEP as a network. A lot of these facilities feel like they're the only ones out there, and this was a brand new program last year. And so our various peer communities we established beginning of last year, we have a program manager, care coordinator monthly call. We have our physicians who get on the call. And when you start putting peer-to-peer, a lot of good stuff can come out of it. Our first few were basically monthly phone calls, and it just felt like crickets on the call. And so we decided to bring everyone face to face, and the dynamic changed once, the person who on the other end of the phone knew who that person was and their facility and their problems, and our phone calls got engaging. I mean, they were fabulous, and those continue monthly. We share care plan ideas, problem patient ideas. They have their own network that they can refer to. Physicians who don't want to hear from the care coordinator of what's best for them to do in participating with the ACO, we have a fabulous medical director who's a physician lead in one community, and he will go and meet with providers individually at our different hospitals, and it's amazing, the provider engagement we've had post our physicians visiting them. A lesson we learned is, care coordination is a very gray job, and it really does require a certain type of nurse. And what we found out last year was, it's really hard for an emergency room nurse, where an emergency room is very black and white, to grasp a lot of the role of a care coordinator, because what you're doing is constantly changing. We've discovered that, just in our work, it may speak differently in another community, but a home health worker is really a great fit, because the work of a home health nurse is very much like a care coordinator, always having to look for different resources and, engaging the provider, engaging the family, et cetera. Patient engagement. When our ACO started, and I mentioned we were cross-referencing lists to go for that top 10 to 15% of our high-cost utilized, you just can't pick up the phone and call them. Cold calling them was not successful. Now, this day and age, when you're talking about our elderly population, and, there's fraud and different types of scams have just really scared them. And so we have found great success in face-to-face. If that patient has an appointment, yes.
Tara, we're kind of running out of time, and we have one more speaker. Would you mind kind of wrapping up quickly? By the way, this is fantastic information, though. Thanks.
No problem. And so basically, code everything, make sure our data is entered right, be patient, because ACOs are constantly changing, and basically he who holds the data wins the game. If we can get good data in and pull the data out, we'll be able to make strides in our community.
Yeah, thanks, Tara. There's such a wealth of information there. I really encourage you to take a look at it, because this is really what the evolving knowledge and wisdom we're gathering as such. So I totally appreciate Tara sharing with us. And this call will go over a little bit as well, because we want to give Gina full time to talk about the Appalachian Kentucky Healthcare Access Network. The other thing is, we've got more questions than we've ever had in any call. We will answer those questions. That we will, those that have asked the question, we will kind of connect you with the speakers and make sure that every one of the questions that you put in are answered. So if you want to put in additional ones, feel free to do that. So with that, I'm going to introduce our last speaker, Gina Bryan, and as I mentioned, she's going to talk about some really incredible stuff that they're doing out in eastern Kentucky. So Gina, I will turn it over to you.
Thank you, Terry. Just a little bit of background as to where we are located and how we became kind of centered around community health workers. We are in central Kentucky, but we are just on the edge of the Appalachian Mountains. So we refer to us a lot of times as Western Appalachian counties. But we got into working with community health workers about 2006. We had received 3 consecutive rounds of HRSA outreach funding, and with that we worked to have a consortium, also known as the Appalachian Kentucky Healthcare Access Consortium. We served 3 counties, our own county and 2 surrounding counties, and we had 3 full-time community health workers. We covered chronic disease as far as our model through a home visitation program. We are now in our 4th round of HRSA outreach funding within our own CHW program, and we've expanded for 5 counties where we have 5 CHWs total on staff. We are just a single independent county health department, but when we started looking at what we were finding in the health of our own CHW program, we knew that this was something that we really could work to spread out to all those rural counties in Appalachia, Kentucky, some of those being the most underserved counties in Kentucky. At that time, our consortium decided to expand to a full network, and we started adding partners to our network that represented these 32 counties in eastern Kentucky, which is what we consider making up the western portion of the Appalachian Mountains, if you can picture the Appalachians running through West Virginia, North Carolina, and that type of thing. As a network, we determined that our vision would be to increase and improve healthcare access for all the low-income, uninsured, underinsured residents, both documented and undocumented, of rural Kentucky. Here where we're located, we do have a large undocumented Hispanic population, so it's important that we look at doing things bilingual, and we even have on our staff here bilingual CHWs. Our mission of the network was to increase the number of community health workers in the Commonwealth of Kentucky by expanding our network to include partners throughout that western Appalachian Kentucky region. And we really wanted to focus on developing training programs for CHWs. That seemed to be where the state as a whole wanted to move, looking at all types of training programs, certifying CHWs, credentialing CHWs, and that kind of thing. We then decided to take a look at our network members, and I'm not going to read all those off, but you can take a look at the list there, and what we did was to make sure that we had people with experience in both rural health, education and curriculum, workforce development, and we also wanted to target agencies who already were using CHWs or had an interest in beginning a CHW program. We wanted to make sure, too, that for those that already employed CHWs, that we had them on our network to be our champions for those other types of organizations. So, for instance, our local FQHC that we have here, Sterling Health Solutions, they have CHWs on staff there. One of the things that helped promote for them was being able to secure a patient-centered medical home status. And so we know that by having Sterling Health Solutions on our network, that as we expand in this 32-county region, these other FQHCs can look to Sterling Health Solutions to say, how did you use CHWs? How has it benefited your staff? How has it benefited you financially? How has it benefited your community? So we really want to target people on our network that we know will serve as champions in spreading that workforce of CHWs into those other areas. And as I stated in our mission, our overarching goal was to have more trained CHWs that would be employed across Appalachian Kentucky. Our executive committee worked hard to evaluate the other states' curriculums, how states are certifying and credentialing, and we determined that we had all the necessary components of what we felt like CHWs needed to be trained in. It was a collaboration of the network members, each bringing what they had in CHW training to form what we have as a standardized training plan in this tiered training approach. We felt the tiered approach was the best format. So Tier 1 is the basic curriculum training, where all CHWs, no matter what type of diseased population, what type of an organization you work in, we feel like this is the training every CHW needs to have. It's just a basic curriculum. It's a one-week classroom-based curriculum. It is already in existence that was developed by one of our network partners. So we as a group decided on this as a basic training. We then started looking at specialty training for more specific chronic diseases. We wanted to make sure that what we were looking at here was evidence-based programs, So the network then began to identify other members within the network that would serve as master trainers for these evidence-based curriculums. And we've worked hard to certify several individuals as master trainers that can go out into this 32-county region and train the CHWs in these other programs. We did come to a collective agreement as a network that we wanted to make sure that all CHWs did go on in Tier 2 to receive training in the Stanford Chronic Disease Self-Management Program and also to go through a mental health first aid course. Now, we were looking at some other evidence-based curriculums that we have master trainers in, things related to asthma and diabetes. And this would be left up to the discretion of the employer if they felt like the CHW that they have on staff is one that needs to have these other particular diseases. And if so, we have the ability as a network to provide that. This, again, is just an example of the importance of the network and the collaboration that they provide, and the fact that not one agency or entity, as rural as we are in Kentucky, can be the only provider for all of these courses. So the fact that everyone was willing to step up and identify people that can be those master trainers has been very helpful. When we look at the triple aim, this kind of makes you look at why do we want to have trained CHWs as part of a healthcare delivery team. We're very adamant here that CHWs are going to be an integral part of healthcare transformation. We know that when we look at better health, that when we have CHWs that are trained in evidence-based programs, they can provide those self-management skills and techniques and teach their clients. When clients have those skills, they're better able to manage their disease and condition. The CHWs can help the clients set goals and work on objectives to meet their goals. We know that self-managers have fewer sick days, fewer doctor's visits, less emergent care needs. And we also know that clients that have increased self-efficacy to manage their own chronic condition report a higher perceived health status. And this is something that we target in the evaluation of our own in-house CHW program. We're very focused on self-efficacy, and that is something that we have reached statistical significance in our own current program, that our clients are showing that self-efficacy to manage their diseases. We want to look at the care. We know that CHWs will serve as advocates for that individual on behalf of their needs. CHWs are integral in helping clients establish a medical home. They help the client facilitate that patient-provider communication. They can work with the client prior to appointments to help the client ask questions and encourage them to know what to talk to the doctor about. They provide care coordination that ensures that there's continuity of services, that there's follow-up, that no one falls through the crack, that has a CHW working with them. CHWs build trusted relationships with their clients, and what you find is that clients are more willing to do what's asked of them to help with their health and help take care of themselves whenever you have that relationship that has built between the CHW and the client. CHWs, when we start looking at the cost, when you educate the clients on proper healthcare utilization, which is very important when it comes to uncompensated care. And that's something that we are extremely focused on within our network right now. We are looking at a return on investment study that has been going on for almost a year. It'll be complete in July, and we will share that with our entire network, and then from there, anyone that is interested in it. But we know that in going through this return on investment and the things that we are focusing on, that our CHWs are able to help clients obtain needed medical coverage. We're fortunate in Kentucky to be a part of a Medicaid expansion state, so that has helped tremendously. We know that when CHWs help to teach these clients proper medication adherence and help them understand attending those primary care and specialty appointments as scheduled, that reduces the risk of that improper use of healthcare utilization. We know that when CHWs work with their clients to help them monitor values like their blood pressure and their blood glucose, again, that reduces that non-emergent care need of an ER. It also helps with those hospital admission and readmission rates. Those begin to drop. One of the things we're focused on is that decreased burden on hospitals for not receiving reimbursement when there's non-emergent care, which is something that we find here in Kentucky in a lot of rural hospitals, dealing with the reimbursement because of someone attending the emergency room and it wasn't an emergency.